do this. So welcome everybody to the Academy of Leadership Sciences Switzerland. Everybody can hear me well? Paul, you can give me some feedback and you can see the slides as well. Welcome all of you, and our subject for today is the impact of leadership and patient safety in managing the coronavirus crisis. I'm very honored to conduct this lecture together with a colleague of mine, Professor Dr. Paul Barach. And I'm very honored as well. I just saw before the other colleague of ours. It is Professor Dr. Max Manno. Welcome, Max, again. And we are very honored to present this interactive lecture. I'm gonna go with some presentation now, presenting first a colleague of mine, Professor Barach. 2 or 3 words about myself and about the Academy of Leadership Sciences Switzerland. And Professor Barach will carry on then with patient safety part. I will carry on afterwards with leadership, and I want to involve, of course, with a great pleasure, a colleague of mine, Max Manno, which has done a great study in Latin America regarding leadership competencies. I just want to mention that last week, Max, yes, it was that we conducted one workshop, which it was a great workshop regarding leadership and emotional intelligence in order to overcome those crises as well. We will carry on with this lecture and we will not stop with this because I'm honored to work with great people worldwide. So just some words about Professor Dr. Paul Barach. Of course, I could talk now, I think, the whole afternoon and evening, I think, in my part of the world here is evening, about Professor Barach, but just a couple of things about him. He's a great scholar, as you can see. He has done a lot of research. He has done a lot in academics, and he's MD, he's MPH, major retired in the Army as well. Leader of public health, as you can see, and focused very good in disaster and preparation and to prepare actually for those crises as we are now as well. And team training, patient safety, he's one of the actually most familiar scholar in patient safety worldwide regarding quality management as well, performance improvement, and system change. He trained at Massachusetts General Hospital, which it was affiliated with Harvard Medical School. He has over 20 years of clinical and administrative experience in academic medical centers and integrated delivery systems. Professor Barach is a double boarded anesthesiologist and critical care physician scientist. Of course, at the moment, he has a lot to do now as well in the clinical part of the world as well. Now, regarding the coronavirus as well, he will share with us more, of course. Clinical professor at Penn State University School of Medicine and lecturer and senior advisor of Dean at Jefferson College of Population Health. He holds visiting professor position in Austria, Australia, Pakistan, Korea, and Switzerland. We are very honored, Academy of Leadership Sciences Switzerland, to have Professor Barach as a faculty as well here. And Professor Barach was Chief Quality Officer for the University of Miami, as you can see here, Jackson Memorial Healthcare System. And he's Associate Dean of Patient Safety, founder and director of Miami Center of Patient Safety and Simulation. So you can see that his research and his experience in patient safety is extremely big. As you can see, he has worked and works further in and actually trains anesthesiologists as well. He leads the Patient Safety Commission for the World Society of Intravenous Anesthesia. He's a board member of the International Academy and Design and Health, focusing on innovation, facility design, including for disasters. And I think his experience, which he's prepared, will help us very much, because we really are deep in crisis worldwide, in Europe here, in Switzerland. I just talked to a colleague of ours in Saudi Arabia, in South America with Professor Mano as well last week. So we all actually face this crisis, and this was actually the aim of this lecture as well, that colleagues of ours from healthcare especially, but even beyond that, can profit from this lecture. He spent 5 years in military working on the disaster preparedness and work, and involved in developing team training, leadership and simulation training for disasters. And his work has led to over, as we can see, 14 billions in federal competitive grant funding as well. He serves as an editor of British Medical Journal Safety and Quality, and we know that British Medical Journal, it is a very prestigious journal in healthcare and medicine, and has published more than 300 scientific papers and 5 books. And his work has been cited in more than 10,000 times. He's widely so as an outstanding, actually, speaker, as a keynote speaker, and I had the opportunity with him, the time goes quick, for 2 years, I think, or 1.5 years in Emirates to speak together. And so we have decided to work together, of course. And together with him, we have a lot of programs and a lot of projects which are going on. Yeah. So about me, I am the CEO of the Academy of Leadership Sciences Switzerland, and I hold PhD in medical education. I have done during my PhD that time a big study regarding leadership. That's why I'm very much involved in leadership, investigating 3 German-speaking countries, Germany, Switzerland, Austria, and USA, Canada, and UK, regarding leadership competencies. And we came with one module of leadership competencies that holds my name. And I've established, not alone with my ex-professors, the Academy of Leadership Sciences Switzerland, and I'm honored to share with you that we have more than 50 people on board, outstanding leaders such as Professor Barach and Professor Mano, which are now present in this lecture as well, but some other colleagues worldwide, and our aim is to train and help people to become outstanding leaders. So I'm very honored. I can see that I have Professor Bali here from Saudi Arabia as well, which he is about to finish his Master of Science in Leadership and Dentistry Education. And he's doing a great job, by the way. He has almost finished, actually, and I was very glad and honored to read his master thesis, and definitively a part of it he will publish. So I'm really very much looking forward to that. And this, makes a great thing, having to deal with the great people worldwide with the same aim, making better leaders, making more competent leaders, because leadership, it is always a challenge, all of us. But to make sure, I don't want too much to talk about myself, but I did a part of my study here, of course, in Switzerland, University of Bern. I was very much focused in medical education, doing there my master. Afterwards, a part of it at the University of California in Los Angeles and in Chicago. And afterwards at International Graduate Medical Education. At that time, it was Professor Violato was the director of University of Calgary. Over there, he was my supervisor, and really I learned a lot from him. So as I said, I have done my PhD, and he was my mentor. And so I have been teaching as well, almost more than 20 years actually here in Switzerland in graduate education, but postgraduate education as well. And I have established one program as well for international graduate medical education doctorate program, and I do teach PhD over there as well. And I'm a supervisor at ETH. It is a Swiss Federal Institute of Technology in Zurich, which it's always actually, it is the first university in Europe, but it ranges, let's say, not now to exaggerate, but between 4th and 10th worldwide. It's always the best. So yeah, so what I do advise as well and coach institutes and key leaders here in Europe and worldwide as well. And as I mentioned, I have developed Çitaku's leadership competency model. As I mentioned before, I will later on, after Professor Barach, I will say something about that and give the word, of course, to my colleague, Professor Mano. And so we have published that in British Medical Journal, a part of that study, as I said. And so my actually domains are leadership and emotional intelligence, of course, which I do teach, but quality management as well, leadership and organizational theory, and so on. And I just wanted to share with you some of our projects which we have done with Professor Barach, and we will carry on, of course, and do further, and with Professor Yavar Khan as well, who cannot join us today. And so workshops in leadership and patient safety. So we wanted, actually, as you can see, I come from leadership. Professor Barach comes from patient safety, but with a strong background in leadership as well. And we are trying to help our colleagues worldwide, you know, to become more competent leaders and, you know, to focus on patient safety, that, you know, the patients leave the hospital safety after they came to us. So we are carrying on actually with those workshops. Now we know due to this crisis, now virus crisis, we cannot meet face to face, but we are in the preparation of offering all of those trainings online with such facilities as we are doing today, and so on. So you are more than welcome. You know, people from all over the world, individuals, but of course organizations as well, which we train together with Professor Mano, Professor Barach, of course, and we have, as you can see, Professor Khan here as well, and many others, just to name some of us. Well, I will just a couple of words inform you about the Academy of Leadership Sciences Switzerland, and as I mentioned before, then Professor Barach will carry on, and then I will carry on further then. So Academy of Leadership Sciences Switzerland has been actually established due to those results which I mentioned before, which was a big study, those Western countries we have investigated. And we wanted to offer people opportunity to enhance their leadership competencies, because as we know, all of us, you are, and me and everybody is extremely good in one domain, let's say, but you know, in the whole world, and we are now in medicine and healthcare today, so we hire people actually due to those technical competencies, but unfortunately we didn't till now teach them how to lead, and that is a big challenge. Once they go in that position of leadership, and we haven't trained them at all, so that is a problem. It would simply be, he was a very good surgeon, he was a very good internal medicine anesthesiologist and whatever, but when we hire them in the leadership position, it is the problem because we didn't train them at all, actually. And that was the aim for us, to fill that gap, because it was a gap in that domain, and offer different kind of programs. So we are based at the World Trade Center Zurich here, but of course I have to admit this is not our building, but our offices are, you know, based in this World Trade Center. And when we have sessions face to face, you know, we have just below, actually, in this building, as you can see, very good rooms, which we, of course, we can use them. So we say that leadership is learnable, and our mission is indeed to make outstanding leaders. And as you can see, so we have to deal with academics. So we do offer courses of advanced studies, which it is Certificate of Advanced Studies, 8 8-week certificate. Then we have Diploma of Advanced Studies, we have Master of Advanced Studies. So we are very much focused actually in advanced studies. And we do, in collaboration with some universities, offer a Master of Sciences, which Professor Fadil, for example, is doing that as well. And we do, as I said, so we collaborate with international graduate medical education in Calgary and with CAS in Paris as well. And together with them, we do offer doctorate and PhD programs as well. But I didn't, put them here. We are very much focused on research. Almost every student of ours does publish, and we of course help them as well. But together as well with colleagues now, we are just about to publish with Professor Barach and Professor Mano as well a paper. And we have done with Professor Mano many of papers, by the way, together and with other scientists worldwide, of course. But we are very much involved in advising, coaching, and consulting individuals and organizations as well, as I said. We cover those domains, leadership in business administration, including specializations. There are 27 programs over there. We have leadership in higher education because it is a lack here as well. I come from medical education, I know that. Leadership in politics, so we know the biggest disaster it is and the biggest threat, by the way, it is due to the non-competent leadership in politics, for example. And we try to help them as well and to support them, to advise them, but of course to teach them as well. There are plenty of programs over there as well. Leadership in healthcare, we have here as well a couple of them, and it is very innovative, which we have developed for the very first time worldwide, by the way. Leadership in dental education as well. Leadership in dental education, which Professor Valo is almost finishing that program, as I said. And leadership in law as well, and I know it is innovative as well, actually, because we wanted actually to capture that, to fill that gap, as I said. And I know I have two lawyers in the family, sister and brother, and they were asking me, we never heard about leadership in law. And I said, the best positions actually you lawyers have without learning any day how to lead. So that's why I'm doing that. And it was interesting, the first student we have it was a lawyer. Partners, we have just few of them to mention here, but we have many more actually in the meanwhile, which we collaborate with Emirates, Barach University over there, and Ambrosiana as well, Calgary, as I said, strategic development worldwide in US, RIFA in Pakistan, and so on. And we have established Center of Excellence in Zurich and in Dubai as well. It's in Ras Al Khaimah, about 1 hour drive from Dubai, but worldwide, when we talk about Dubai, everybody knows Ras Al Khaimah is 1 year, lovely place over there. I know Paul went many times, Barach and myself as well. And the aim was actually, as I said, to train people, as you can see, because I'm going to go a bit quicker to this session. So we have conducted many workshops over there, as you can see here, some sessions and in US and elsewhere here in Switzerland, Europe, and so on. We have many MOUs, so we have this with Barach University, just some inserts here. And I like that people want to learn leadership, and we had really high stake people over there, such as ministries of education and ministries of healthcare and so on. And I know for myself, I was flying from here to teach over there as well. But to make it short, I like that actually we wanted, the people want to learn more. So I'm going to finish here, actually, my talk at the moment for a while. I'm going to give the word to a colleague of mine, Professor Barach, and then after him, I will carry on with this part of science from the leadership and how this can even impact to the current situation. And of course, I'm very delighted to have a colleague of mine, Professor Mano, as well, which of course we will share together then this part. So Paul, the floor is yours. So I'm gonna stop this here, and you can start with you over there with your slides. Perfect. And I know virtually the floor in US now, but virtually you have.
Great. Can you see my screen?
Yes, we can. Yeah.
Great.
And we can hear you very well. Yeah.
Okay, just take a moment.
Yes, please take your time.
Files. So, good afternoon, everybody. It's great to be with you here from the US. I want to talk about a variety of things around COVID. I'm going to skip through several of them. I have no meaningful disclosures. These are the objectives, and I'm glad to give you a copy of the slides afterwards. So I thought we'd start with some history. You know, this, of course, is the famous Athenian plague. And the Athenian historian who documented this in the Peloponnesian War, I think captured very nicely where we are today, and that is that neither the physicians or management could do much to help when the outcome is very interesting. Despite lots of efforts, we still don't have any targeted treatments, and I'll speak to that a little bit later. So we all know about the coronavirus by now. We know about the risk factors. We know about the infectious, so-called the people it can infect. And it's clear that about 5% of people that get infected become critically ill, and of those, probably about 30% die, and we'll speak to that as well. This is a snapshot from yesterday to give you a sense of how infectious this is. And 95% of the countries in the world, the rapidity in which this spread is quite extraordinary, and I think lots of politicians argue that this was more than the common flu, have now sort of realized that they were wrong. Again, this is Europe this morning, showing you the number of deaths across different countries. On the top right, you see the number. On the bottom, you can see trying to control for population, and from the first death that reported. Again, a very eerie pattern to these things. So I'm hoping this shows this a graphic which shows how quickly over the last 3.5 months this has spread. And when you see it this way, it's really, it takes your breath away to see how effectively this virus has spread itself pretty much across the entire globe. Now, I want to also highlight this key issue, which hasn't been discussed enough, which is nursing homes, long-term care. Different countries have different names for this. In the US, about 22% of the fatalities have been in nursing homes. In the UK, it's been about 29%. Nursing homes turned out to be a perfect structure for harming people, as well as care. We've known for a long time that nursing homes where we put our loved ones were not particularly well equipped for chronic illness, and all of that is sort of roost in what's become an incredible challenge. In the US, it's close to 2 million people, in about 35 million people that live in nursing homes or long-term care or aged facilities. And so how do we best protect them as we go forward? As a reminder, we still think that most of the carriage is through droplets, although there is some controversy in the literature. Could some of it be through aerosol? And if it is aerosol, what does that mean as far as our protection? Because obviously aerosolation dramatically changes how we protect ourselves, particularly in the context of how we go back to work. So these are the symptoms. You've heard about this. On that, but I'm glad to answer questions afterwards. This is the pathology. This is the virus works. It seems to affect particular cells, particularly what's called the pneumocytes. It damages them clearly. It causes a cytokine release. And we'll talk about some of the systems that get damaged because of that clear pathway. Here you can see the transmission, particularly the lung, the GI system, and with some direct injury to the direct myocarditis and an endothelial damage, which is not just in the heart, but particularly damaging to the heart, but probably explains the incredible high rate of clots. Some studies, as much as 1/3 of patients have arterial or venous clots. Here you can see on the left is a typical x-ray. This is a patient that I took care of a few weeks ago. In the middle is a CT showing a traditional kind of ground glass appearance, and on the bottom is another CT in different cuts, and you can see how this looks like in early days. So here's the CT, and you can see how, as it runs through the various cuts, damage, which is widespread across most parts of the lung. And this is what causes the dramatic hypoxia, in which these people seem to be able to talk fine, and they think that their PO2 levels are as low as 70 and 60 on room air. Again, here's some pictures from different ICUs that you're familiar with. So the clinician's dilemma is the hardest one. So above and beyond the macro system, which we'll talk about, what does a clinician do to treat these patients? We know from the science of implementation that there's challenges between the beliefs that we have, the knowledge that we have, the traditional practices that aren't always based on evidence, and evidence. So how much evidence do we actually have to treat these patients? And I imagine many of you have heard about people advocating high-dose vitamin C, and they've advocated hydroxychloroquine, they've advocated bleach, as I'll show you in a moment. So I want to go back to the science of learning. How well are we learning from our past knowledge as it relates to better treatments? This is the father of all learning systems. This is Deming, the reason why industrial systems around the world. And I believe that these 4 principles are at the heart of how to manage COVID, and many of them have not been explained adequately. Number 1, it is a system, obviously. And what that means is that you can't treat COVID in one shop or one street or one city. In fact, this virus doesn't recognize those boundaries, so it has to be a multi-level, multi-system interventional platform. 2, vision, which is the heart of industrial quality improvement is the same in COVID. We're seeing massive variation in how different towns and cities and countries are managing, and therefore dramatically different rates of morbidity and mortality. We need to understand how knowledge is that means leadership and change management, which we'll talk about. This is what the pathophysiology looks like. Lots of so far, very little. This is a paper that was published this morning, a very remarkable paper in Lancet, in which 400 scientists came together, a wonderful example of knowledge transfer, and they summarize all the potential underscore, working all of them potential, just to give you a sense of where things are this morning in the Lancet. So data versus dogma, right? So how many of you think we actually have, and so it turns out that excellent intensive care science is the only way to treat these patients. There are no targeted drugs. And so lots of papers have shown that these magic drugs are simply not working, and they probably cause more harm than benefit. For example, how do we move from data to information, to knowledge and wisdom? And this is a graph that I really like, because it's all about context and understanding. It's clear that optimal management of COVID is highly context dependent. So what works in UAE or Saudi Arabia will be different than what works in Switzerland, and obviously different than what works in the US. This is very, very, and culture is going to drive the speed of the spread, the speed of containment, and the ability to go back to work. For example, on the left is an antiviral drug. There's been a lot of excitement in the last 3 days. The company that makes it to leak this into the media, which could include for the symptom does not. The drug on the right, hydroxychloroquine, causes more death than benefit, despite what my president said. The drug disappeared from shelves. The companies made a ton out of it. Practically speaking, there has been no studies to show that it's been beneficial. When science is led by politicians and not by scientists and people who understand evidence-based medicine. On the right is a mock-up of New England Journal of Medicine of injecting bleach. You might have heard last week my president suggested that perhaps we should inject bleach because it's so effective in curing viruses. This wasn't a joke. This was serious.
Okay.
There are thousands of people every year around the world that die from bleach, either intentionally or not. We as scientists have to come up loudly about the dangers of having politicians who are not just clueless about science, they use their bully pulpit to damage all of us. So this is the most recent data summary. On the left is the NIH, in the middle is JAMA, showing that as of last week, there are no therapies that have been shown to be effective to date. What is effective is excellent, well-known critical care, good nursing care, good fluid care, good respiratory care. That there's good evidence, but none of these magic bullets thus far have been very helpful. Parenthetically, while knowledge transfer is important, and it's wonderful that journals now are allowing everybody access, but I believe at least half the papers that are released are garbage. They're poor science, they're not well randomized, they're not well controlled, and they lead to the media the next day to say, oh, we found a new cure. And I'm sure you're all whiplashed by all these media headlines. There's a new cure. The bottom line is there are no new cures at present. And so we have to be very careful to balance the release of all this data and to temper it with the fact that there is a process that we have to review before we can drive it into clinical care. So these are the basic steps that we know about: physical distancing, so-called non-pharmacological interventions, travel bans. But how long can we do this? You've heard about the damage to the economy. In my country, 28% unemployment. In many countries, it's between 20 and 40%. The price of oil has dropped to beneath zero. And lots of people are not making any income, and so the fear of poverty and hunger is not far away, according to quite a bit of models. 1918, the pandemic that killed close to 50 million people, the only solution was distancing and masks, and ultimately within 18 months it burned out, it went away, but only after it killed a fair amount of people in the world. So this is sobering that we're looking back to an event 100 years ago. But in fact, some of the best evidence we have, both financial and clinical, comes from that event. These are pictures from this week. This is Orange County, California, 4 days ago. In the left is Malaysia 2 days ago, and in the right is Tehran last week. Look what's happening in these pictures. There's no distancing, there's barely any masks, and people are coming together. This clearly is going to cause a propagation of the epidemic around the world. This is the president of Brazil 2 weeks ago. They already had close to 1,000 deaths. Now they have 4,000 deaths, and the president was wiping his nose, touching people, and having public events. Clearly, when politicians propagate these events, I think we should hold them to account. And I believe that this is an unethical violation of the Helsinki Report, the Belmont Commission, et cetera, et cetera. Again, Bangladesh, last week, 100,000 people showed up for a funeral. Clearly a tragic event which is going to lead to thousands and thousands of people being harmed by this. This is 2 days ago, my vice president going to the most prestigious hospital in the US, the Mayo Clinic, and violating the rules, not wearing a mask when everybody was supposed to wear a mask. And then later on decided to sack the people that leaked the picture and leaked the media. This is a remarkable example of a fascistic example where governments try to control the message and are hypocritical about their behavior. So here's the evidence. Masks absolutely work. And I recommend that we wear masks, despite the fact that the WHO has still not recommended it, which is rather amazing. Here's the data. On the right, you can see that if you wear the mask correctly and you wear it 100% of the time, the R naught, which is the ability to infect other people, goes down by 90%. Here's another example from Hong Kong, published last week in The Lancet. They were able to reduce the R naught from 1.4 to 0.7. Remarkable. This is a logarithmic curve, to be clear, and this is by non-pharmacological interventions. Hong Kong has been one of the highlights of countries around the world, despite their density, being able to have a relatively low number of injured and infected. So here are some of the questions that we're looking at. So I'm curious to hear your thoughts when we ask questions. And by the way, I encourage you to write questions now that we can respond to afterwards. These are the questions that we're looking at. How do you protect your employees? How do you protect the public? What are proper policies for coughing and sneezing? How do you screen people? At what distance? How frequently? How do we clean surfaces realistically? Do we do masks, everybody, or gloves? Yesterday I read that all airlines are going to be requiring masks for everybody that flies. Interestingly, starting May 1st. How far is safe enough to be distanced? How do you protect high-risk employees, people that have a history of cancer or psychosomatic or other illnesses? How often do you test? Do you test for PCR? Do you test for antibodies? And how do we better educate the public in a true co-production, co-design model? I want to introduce a concept that we in human factors have been using for 40 years, and this is the concept. Many people think they understand how people work on the front line. For example, if you've ever worked in a kitchen as a bellboy or a chef, you know that distancing is a silly concept. You are literally in each other's face. When you work in spaces that are very, very tight, it's very different than what people perceive that. So in fact, it turns out, for example, that the most dangerous place in retail right now is being a cashier, because cashiers are exposed to so many people. And so people are trying to protect cashiers, because in the US, as much as 24 cashiers have died from COVID, from being exposed to customers, so-called essential markets. So again, we have to understand that if we're going to protect workers, we have to better understand their workflow, how they talk, how they work. And that means a complete redesign of many working spaces, including home, including wearing all kind of different types of gear, including rethinking how do we do what we do. For example, taxis won't disappear, but perhaps we only allow one person and not 8 people. So very briefly on the tests, I imagine your list on the left is the PCR, IgM, IgG. As you can see, there's a huge amount of variability between the PCR, which is the only test that identifies live viral products. However, it tells you nothing. That is to say, are the people able to protect themselves from future exposure? Up until today, most of the data suggests that these antibodies are not protective. However, this morning, South Korea is publishing data suggesting that so far in retesting of people who have been infected and have convalesced, they cannot be reinfected again. Early data, unclear how realistic that is. The point in this story is, you can see, is that there's a huge amount of variability between when you're sensitive to be tested and how long antibodies will last, and will those antibodies protect you? And it's going to take weeks to months to understand this. It's clear people are scared to go back to work. It's clear that politicians are nervous about not going back to work. How do we find that balance between these two things? And it's not an easy thing. And so Fadil, I think, will talk about the leadership issues here. Here is some data from the last few testing. As you can see, the UAE has done the most tests for population. The UK has done the least tests, which is very, very interesting. And again, smaller countries, obviously easier to test a lot of people. But Germany, for example, with 80 million people, has done one of the highest number of testing in the world. I think that's a testament to their quality of their public health system and the willingness of the people to get tested. Again, this uncertainty around how long is it antibody protective? Very, very difficult questions, which I'm glad to answer. Here are some examples of booths around the world. It began in Hong Kong on the top. In the middle is in Bern. In the right is Mexico, Israel. This is how we protect our healthcare workers during testing, because we know that hundreds of doctors and nurses and other healthcare workers have died from COVID in treating patients. We must protect the healthcare workers. Here are other examples around the world of booths and other things that are being used to test people. So, but we've not taught people how to wear masks. We've not taught people how to put gloves on. And again, it's clear, unless you use the mask correctly, they're not as effective as they are. It's a little bit like when you buy a device like a computer and it says your laptop will last for 10 hours without recharge. You take it on a plane and maybe it works for 6 hours, because you're not using it properly in optimal conditions. And so we have to be very clear about how we train people. And I think we need to train people how to protect themselves, which means how to gloves, how to wear a mask, how to wash their hands, and I'll talk about that in a little moment. So healthcare workers, the priority of my work, prioritizing their testing, housing, meals, childcare, licensure, liability, many, many things which need to be done. And some countries are leading with this. Others have neglected care providers. And it's when healthcare providers have been told, first of all, we're not going to get proper equipment. And if you bring equipment from home, we're going to punish, we're going to fire you. This happened in the US in several places. It's happened in Mexico. I don't know if it's happening in your countries as well, in which nurse doctors and allied health have pleaded for personal protective equipment and haven't been given that. Here are examples of clinicians not using equipment correctly. And so just wearing some PPE doesn't necessarily protect you. You need level 3 protection when you're dealing with a highly contaminated area. This is an example of a picture that was sent to me from Mexico. A nurse was given this as sole equipment to protect herself from COVID. You can imagine, as you can see through this, this will not protect the nurse from COVID. So I love the Germans. Samira, you're up there. This is what the Germans published last week. This is the German Medical Association talking about what it feels like with nurses, because this is how I feel when I'm not protected properly. So the fear, the constant sense that I'll be contaminated, that I'll contaminate my family, that I'll contaminate my colleagues, is an extraordinary problem. We must use the science of this science that helps us understand workflow, the tools, technology, the process, the culture, all of the stuff that we've been talking about for 20 years around safety and quality is 100% relevant to going back to work, to controlling the epidemic in the hospitals, and to protecting our healthcare providers. And talking and nurses. We're talking about porters and people that bring the food and people that clean the floors. They're equally likely to be exposed to infections, and so we have to protect all of them. Again, the science of human factors, leadership, and communication are the top 3 reasons why the Commission says we're no different than pre-COVID. I fear sometimes that because of COVID, safety and quality, it's no need 30 years safety and quality. It's, of course, we build our own knowledge on safety, quality. Again, this is data over 110 dead healthcare workers in the middle is China, and on the left is a Medscape database, which includes close to 1,000 doctors, nurses, and healthcare professionals from around the world. Here's some data from the US, very detailed studies showing when these people got infected and how long they were infected until they died. This is from Mexico. This is a car, a car of a physician that was sprayed with, "Go away, you're contagious." And then the left on the right are notices that were put on doctors' houses. "Do not come home, you're dangerous to our neighborhood, you're not welcome here." This is extraordinary stigmatization of doctors and nurses. We must speak about this. This is terrible. This is adding to the mental anguish and mental unwellness that healthcare providers struggle with. This is the levels that the Chinese have published, and I think they're very good. Level 1, 2, and 3. At the minimum, level 1, medium, level 2, and of course, if you're doing aerosolizing procedures like bronchostomy or tracheostomy or intubations, you need level 3, just like you're dealing with Ebola, no less, because we know otherwise you get infected through your ears, through your eyes, through your skin, through your hair. All these surfaces can contaminate you. And so we need to get better in training our healthcare providers and convincing our healthcare leaders that it's not acceptable to put people out with simple surgical garb, which is not for level 3. Maybe it's level 1, it's not level 3. The human factors model, if we're going to train people for PPE, we have to just train them and better policies. They need to have buddy checks, we need to audit them, and we need to make sure there's force function so we separate the contaminated and uncontaminated patients. I want to just remind us all that teamwork now is more than ever important. This is my favorite book, Patrick Lencioni's work, and he talks about the fact that if there is no trust, team members in healthcare and outside of healthcare will not trust each other. Because if they won't speak up, and if they won't, never truly be accountable. You cannot improve the outcomes of COVID care. Talk about ways to get our teams to trust each other, to work together. And I'm happy to say that many hospitals have brought together a variety of healthcare providers to work together in a very, very different way. This is some work that we did 10 years ago. It's called Team Steps, used in about 40. As far as I know, it's the only team-based training program that's evidence-based, demonstrates close to 18% reduction in mortality. It focuses on knowledge, skills, and attitudes. And I'm going to send the papers if you want to send me a note offline around this. So I love this Malevich quote that we need to take uncharted waters. I think we're in an incredible, sobering time now. The world, I think, will never be the same after COVID. I don't think that's an exaggeration. And that means we have to adapt. We have to adapt in good ways. Lots of red tape has gone away. We're much more creative, I think, in being able to work together and collaborate. But equally, it means we need to make some tough decisions as far as how we plan our cities, how we plan our workflow, how we plan our organizational models. There's going to be a need, assuming this continues as it is. And there's no reason to think that before a vaccine is available before January that we're going to have much relief. By then, according to the models, the most conservative models suggest that about 100 million people will be infected, to 5 to 8 million will die by January. So that's the conservative model, and that's assuming one cycle. All other pandemics have had multiple cycles, even just mutating. So are we learning as a system? Here's some papers that I use quite a bit. In the middle is the best paper on the AIDS lessons learned. What it argued is that most of the policies that were enacted within the first 5 years after the AIDS epidemic began turned out to be wrong. 5 years. We're barely 4 months. So we need to be much more humble about our decision making as physicians, as scientists, as politicians. We need to be able to say, we don't know. We need to be able to say, how can we do better? We need to be more transparent in our lessons. And so I think we really need to fall back on learning systems. And what is the science around learning systems? That means better evaluation of what we know, better improvement, and better implementation. I think that's at the heart of how we at the Academy will come together, is to offer support and teach the science of improvement, which is no different, by the way, what we were doing beforehand for safety and quality, but now applied to COVID. I'd love to hear your thoughts about that when I finish. Here's a paper that we published on this 9 years ago in the BMJ, talking about how do we evaluate service policy interventions using a Donabedian model: structure, process, and outcome. And I think that's very, very relevant to COVID. And again, I'm glad to talk through that. Again, this is what it looks like. What are the structural elements related to COVID, the process elements, and the outcome? And they're very different. They require different tools to design, different frameworks to measure, and different horizons. And we need to be very clear, this is a multi-level, multi-traditional problem. It cannot be solved at a point. It will not be solved at a point. We know that. And when societies start opening up, what we're going to see is more spread of infection, sadly. And so we need to be thinking carefully about what this means. Snowden from Wales has this wonderful model. If you're not familiar with, I highly recommend you read his work about complex adaptive systems. He separates problems in the world to 4: simple or obvious, chaotic, complicated, and complex. And what he argues is that different problems might look differently at different times of the day, the week, or your level of jurisdiction. What that means is it might be simple to contain us in a house, but it's much more difficult to do a neighborhood, a city, or a country. Or for example, if we talk about distancing might be relevant if you're a computer scientist working at home, but if you cut my hair, how can you be distanced from me? What does that look like? And so it's clear that we need to be much more nuanced and agile in the way we talk about these problems. We need less talking heads talking about simple solutions, and more people inviting us into the science of complexity, the language, the metaphors, the frameworks. This is hard. It won't be easy to get people who want linear solutions, yes, no, because there's very little linearity in complex adaptive systems. And that's the key message from Snowden. We need to rely on the science of improvement. This is a great book that I use. I recommend you take a look at that. And again, this idea, there's many, many tools. For example, driver diagrams. We've been using this for 20 years to improve quality of care. Imagine applying this to COVID. Think about this for a moment. These are tools that every industry has used for decades and decades. Here's another example. These are Showhart. Showhart was one of the master giants of statistics in the 1920s and 30s. These are tools to understand statistical variation, not just exponential graphs that we're exhausted of looking at, but actually things that tell you, is the change over time statistically significant or not, and what will happen under different considerations. This is the science of statistics. We need more of that applied in a more sophisticated way. This is from one of my mentors, Paul Batalden, talking about co-production. How do we engage patients and their families? You know, I imagine in your countries, there's been a drop of close to 50 to 60% in non-COVID hospitalizations, non-COVID hospital visits, 60%. The number of heart attacks has gone down by 45%. Do you think they've self-healed? Are they dying at home? Where are all these patients? This is data from Hong Kong, data from the US, data from the UK. It is remarkable how all non-acute COVID care, or most of it, has disappeared. And I don't think they've healed by themselves. Some of it might have been over-treatment before, but a lot of it, some early data is saying that more people are dying at home, non-COVID, because they're not getting treatment for these symptoms. I want to wrap this up by some good examples of countries that are doing really well. I'm most impressed with Taiwan. This is the data from 2 days ago from Taiwan. Look at that. A country of 29 million people is doing remarkably well. And their secret, and I love this title, was not technology, but civic technology. People, trust, culture, relationships, of course technology, but based on cultural support elements. Here's New Zealand, a country of 6 million people. They believe they've almost eliminated the illness because they did a quarantine close to 2 months ago, and everybody agreed to it because they trusted their politicians. I was very impressed with their cabinet. The head of the cabinet, the prime minister, she and all of her cabinet took a 20% cut in her salary, as a way to show empathy with their citizens because they had a 25% unemployment. Here's another example. Israel, 10 million people, has done rather well. And even though they have a serious political crisis, they don't have a stable government, they're going through political protest. At the picture on the right, you can see 2,000 people protesting, but at a safe distance, and they had to wear a mask. So you can have political action. We do not need to suppress democracy just because of COVID. This is a terrible example of some countries like in Hungary and other places where democratic principles are being trampled on in the name of COVID. Here's an example where they're protesting and they're loud, but they're doing it at a safe distance and they're testing people before and after and they're wearing masks. Not easy, but you can still have democratic tools and principles. I do not think we should let go of our democratic values just because of COVID. We need to have a constant dialogue in that relationship. Here's Ghana, a low to middle income country in Africa. Look at these numbers. If you believe that, remarkable. But again, extraordinary system improvement, extraordinary engagement, smart politicians engage, really nice examples. Again, implementation. What are the gaps? What are the barriers? This is a model that was written 20 years ago. I think it applies very nicely as a potential toolbox for COVID. This is another model that's called Seafarer Model. Here's a paper we just published on surgery. Again, this idea that the internal and external context is going to dictate our success. So as we roll out our societies and open up our economies, many characteristics that we're going to have to think about and measure and feedback are going to drive the success of implementation. If you think opening up your willy-nilly is going to keep you safe, we already know from several countries that did it that immediately the infections went up within days. It's clear now. So 2 words on leadership. Again, resilient leadership that Fadil talked about. Heart, compassion, mission, transparency, truthfulness, and trust. That turns out to be the most important thing. Do you trust your leaders to tell you the truth? And we know there was a massive gap in trust and truth-telling before COVID. That's not gone away. All the issues with Brexit, all the issues, that's not gone away. So this came at the worst possible time, if you will, where the nadir, where the true amount of trust was so low. And so of these leaders, which of them are actually inspiring trust, which is very, very interesting. And again, I love this picture in The Guardian. These countries have done really, really well, and they're all led by women. And the argument was that women leaders are pathetic and more effective in listening to multiplicity of voices, which is a very interesting argument. These countries have done well, and I think it's not just their women leaders, but I think their women leaders have amplified the incredible skill sets of that they've been at once, and that's their core sense of strength. Crisis community key issue that some leaders are effective just death. Again, this is the governor of Como. Slides are very simple messaging, very clarity. New York has been hit very difficult in the U.S. He's got the best remarks of any of us in being very clear, very straightforward, and saying, I don't know, I'm wrong. Not being afraid to say those things, which was very important. So I want to wrap up here again. This is where the and lots of drop in acute coronary events. No reason for that, particularly when people are stressed out, people when they're at home. You can imagine there'd be an increase, but in fact the data. So this is what it looks like. These are in the middle is Kuwait. On the top is China on the left. On the right is Japan. On the left bottom is Korea. On the bottom right is schools in Germany. This is our world, perhaps, for it. How do we live that way? We know that beyond oscillation require training. This is a program that we started training 3 weeks ago for companies, hospitals, employees, how to behave. They don't know how to do this. It's not this and needs to be expected. That means task shifting, staff absence policies, monitor morale, sleeping quarters, quarantine staff, how to use them at high-risk staff, and how to manage the stigmatization of people in illness. We know from Ebola, we know from AIDS, we know from smallpox, many of these illnesses, even when people got healthy, they were still stigmatized by their neighbors. So we have to be thinking what that means for society. We need to talk about how does society deal with these things explicitly. I just want to throw this out. This is a simulation that was released last week. This is one person coughing in an airplane. One person coughing in an airplane. Look how much virus spread happens when one person coughs. 12 people are exposed at least. Remarkable simulations, how difficult it will be to fly again. As somebody who used to fly a lot and hasn't flown for 2 months, I am scared when I see these simulations. So 2 words about telemedicine. This is exciting. This is a paper from the BMJ. Exciting. In the US, there's been an 800% increase in telemedicine. We don't quite know how to do it well, but a lot of experimentations. Reimbursement is aligning with that. We as physicians, as nurses, as systems, are going to have to realize that a lot is going to change. And are we ready for that? Are our bosses ready for that? In the US, many are losing 50% of their revenue, and they've put many staff on furloughs because they don't know how to manage this stuff. So there's got to be alignment of the finance, the regulation, and the care of patients. In summary, this is what the workplace looks like. Hand washing tables, pop-up banners, temperature checks, screenings, track bots, virtual clinics, signage, and we need to have tools available for hospitals, for companies, for airlines, because I don't think society will open up except a little bit until we're able to help people feel safe, trustworthy, that they can trust that they will not get infected, particularly given the fact that it takes weeks to know if you've been infected, and many people infect people for at least 2 to 4 days before they are symptomatic. So finally, these are some gizmos around the world, which I put up there. The police officer on the right, this is a helmet that the Chinese are using in which the police officer can see who has a fever 100 meters away. In the middle is a device, a robot that cleans your house or hospital using UV light, and some other examples on the bottom. Now, we're going to end with this. This is a tracker that's being used in Korea that tells you who you've talked to, who you've been exposed to, and clearly violates all your privacy. Now, the Koreans agree to do this, but given how much problems we had before with Brexit and the US elections and what happened in Europe around the scandal in the UK and around how Facebook and others have behaved, do we trust our governments with this much data? Will they not use this data to monitor our behaviors? Will they use this to this? This is a tough question. We need to talk about the intersection of technology, democracy, and public health. Without that, I'm afraid that we will get more and more angry people that will undermine the trust and undermine democracy in the Western world. So my truly final has been around for decades. COVID management is no different. We need to build a coalition, private-public cooperation with a clear message, with clear obstacle removal towards success And we have to not declare victory too soon, because many societies have already done that, and they've, including Singapore and South Korea. This is a long battle. It's a marathon of sorts, years to deal with, and that means we have to anchor in our respective cultures, in our respective languages, in our mindsets. Otherwise, we're going to fail in what we do. So this is my final thing, George Box, who said, all models are wrong, but some are useful. So I want to end with that. We need more humility as scientists and leaders. And while we love to look at these graphics, the reality is they're only models. So let's be clear, we're going to have to redesign, just like the Cubists did, this new world of post-COVID. Thank you so much for your questions.
Well, thank you very much, Paul. It was a great lecture for all of us, summarizing the newest outcomes, you know, in this crisis, and bringing a lot of insights for all of us, actually, which we have to bear in mind. I'm going to just connect now a little bit about what you said, you know, what the science of leadership, because you many times actually brought that lack of leadership brings us a lot of troubles. And I'm going to carry on there, and at the end we're going to take questions, of course, and I will not, and I kindly invite my colleague of mine, Max, as well, of course, to join me in this presentation and bring his publication as well. So as I mentioned, we have done this leadership competency model, and just to align with that, what Paul very good stated, actually, how important is this social responsibility for the leaders, for the politician reasons, leaders, for leaders in healthcare, leaders in economics, and so on. And all data that I gathered that time in those 3 German-speaking countries, 3 English-speaking countries, at the very first, at the top, it came the social responsibility. And it seems exactly just as Paul said in US, but in Europe as well, unfortunately, many of leaders, politician leaders especially, failed to do that and to show us. They were even, you know, spreading fear, and we know how Paul said as well, how actually dangerous is spreading additional fear, which we already have, you know, as a human being. Innovation, it was on the second time, and it was a second, and Paul very good mention as well. Now we need, actually, we didn't face such a crisis, you know, for a long time, since Second World War. Now we need really innovative heads, you know, and how are the circumstances, how are the politicians preparing our let's say, medium, preparing our circumstances to become innovative. And we know from the neuroscience, because I like this neuro leadership very much, actually, we know that our brain has to be calm in order to get some new insights and innovative thoughts. Self-management, very important. I'm going to go a bit quicker in this, and task management, of course, and justice orientation. You know, how can we manage, even in this crisis, to make an justice orientation, you know, to treat people equal, and so on. We have published this, a part of this study, as I said, in British Medical Journal, and I'm honored to have published this with my professor, Dr. Violato, Claudio Violato, who really has more than 300 publications in the most rigid journals worldwide. And definitively we will call him on board as well, because we collaborate together as well for another lecture, I believe, definitively. And just as I said, not to repeat it and exaggerate, it was a design setting of this study, you know, a population-based study, which we had 2 groups and 2 focus groups, as I said, all those countries. I don't want to now to lose time too much on that, but just those outcomes, because I don't want to really, because of the time, to go in depth, but we had a very rigid methodology of research, really very rigid methodology. You can imagine my professor, Claudio Violato, he has done his PhDs in statistics, you know. And I remember gathering the data in Milan. We were, you know, so we were teaching the whole day, and then in the evening gathering those data, and he was very satisfied at that time and was saying, hey, let's show the world, you know, so leadership in medicine and healthcare. So to summarize that, we came with 5 of domains, as you can see here. which it is social responsibility, innovation, just as mentioned before, self-management, task management, justice orientation. And we had some slight statistic differences for all of those people. Social responsibility was very important. And it is really a coincidence that Paul says, but if you read this model, then it is for free, you can find it. So at the very top, it comes building trust. Actually, the item, it was building trust. So those leaders, they have to become trustful, that people can rely on them and they can trust them. So there were some statistical significances here, differences, but just on statistics, as say, that a little bit it was less high-rated social responsibility and innovation from medical and justice orientation from medical doctors versus non-medical doctors, health professions, and educators in medical education. But as I said, really, for clinical, there is no difference about that. It was everything very important. I'm going to now to show with a great pleasure, the paper that a colleague of mine, Professor Mano, excuse me, sorry about that, I didn't intend that. I'm just going to go back to that paper of Professor Mano. Max, are you here? Can you hear me? Please, can you turn on your microphone?
Yes,
Max, yes, please, yes. Maybe you would like to, and thank you very much for joining us. Max is a colleague of mine. He's an great oncologist. He's a professor at Academy of Leadership Sciences, Switzerland as well, and we have a lot of programs and the projects, just as with Paul, with Max as well. And I'm honored to have been his supervisor. He's a pioneer actually in leadership in medical education. He has done the Master of Advanced Studies at Academy of Leadership Sciences, Switzerland, doing a great investigation in all Latin America. And I was very honored, to be honest, that Max took the model which I have developed for Western countries. He checked the validity and cultural validity in South America. And please, Max, if you don't mind your comments to it, I'm going to try to make it a bit bigger. Excuse me. Can you see it, Max? I mean, yeah, your study. Yeah. I know, but the audiences, I wanted to see it. Please, Max, tell us a little bit about your model, and because it's a great model.
Great, Fadil. Thanks a lot for inviting me, and congratulations to Paul for this wonderful lecture. Well, we decided in summary, very quickly, we applied this model you developed and you applied in a population mainly from Europe and North America. And we felt we should apply this survey elsewhere because there are many cultural variations. So how people value leadership competencies in other world cultures. We have a lot of data from the business setting showing that there is a wide variation, but we have limited data in medical education. So that's what we did. We applied this survey with the support from many medical societies from most countries in Latin America. And that was specifically for physicians, and as far as I'm aware of, is one of the largest specifically done in physicians. And we have some interesting results. Basically, we found some differences. So what healthcare or physicians value in Europe and North America can be slightly different from what we found in Latin America. But also we had a very rich population in terms of cultural diversity with physicians from many countries, and some are Spanish speakers, others Portuguese speakers. And finally, we performed many subgroup analyses. I will not go into detail because we have a lot of data, but we found some differences between women versus men, between country, language, and so on. So many subgroup analysis. So they are published in this paper. It's free access. So whoever is interested to look at can download the paper from the journal.
Well, thank you very much, Max, and we are looking forward to, of course, working together. And just as Paul before mentioned, to help our colleagues, to manage those this difficult situation. But beyond this as well, that there are a lot of it was a lack, and it is unfortunately in leadership. I'm going just shortly, to justify that what Paul says and what Max as well mentioned. We need really outstanding leaders now, and I mentioned before that unfortunately we couldn't teach them how to lead, but it's very important thing, the emotional intelligence, and nowadays, this crisis, it's even more difficult, to calm and to control our emotions, because we come all from healthcare, from medicine, mostly I believe here, and emotions we have there, we cannot amputate, the head or one arm and then they are away. But the problem is, how can we control that? And Goleman, he has a great theory of that actually, which matches very good. And I just did, some, as you can see, actually comparing that. So you have to see people, good leaders, they have to have a very strong self-awareness, because if they are in medical education, if they are in politics and whatever, so they will spread a good mood actually if they are more self-aware about the situation. Now, for example, or they will take the measures, as Paul says, that unfortunately many of our nations, they failed to manage those crises. I remember even in Switzerland, the most safest country in the world, the government was criticized that didn't gather the best microbiologists, let's say, and so on. So you have to be aware of that. And of course, self-regulation, self-motivation, empathy, you mentioned as well. So we have really to fit in the shoes of others and see, how it is that, this is Paul before mentioned, an effective relationship as well. Very important. Paul showed already one paper that this, this social responsibility was in my model and in Max's model as well. Very important. So those things we have to bear in mind. So we have data now. And on the list I'm going to show, and then we will leave, because I think we are running out of time, but we give opportunity for our colleagues to ask. But we are really in one threatening situation, and we don't want to spread fear. Not Max, not Paul, and not myself. Actually, our duty is opposite, to try and decrease fear. But we know now that the anatomy and physiology of our brain. So a lot of data, it comes, from hemostasis and from the actually from eyes and ears and whatever, our sensation, and directly it is connected with the emotional part of that. And if you make really one comparison, is if you can see here about 50 million bits in 200 of seconds, data. And what do we do with that? Do we make a decision in this affect, or do we have time, and patience until this information now physiologically goes to the prefrontal cortex, which is supposed to be, an executive center there. And if you really do now, so one comparison, so we can see, and unfortunately our schools and our education underestimated these emotions and very much focused on this prefrontal cortex to get to know new facts. But comparing that, it is so large as one Milky Way, let's say, and this part, very small actually. So for us, very important as well, which emotional intelligence, it is indeed a part of leadership. And of course, it guarantees you actually a success if you can control and manage emotions. A lot of studies have been now done in this part, and Yale University, Center of Yale University is really very much focused on this and publishing a lot of data. But I just wanted to summarize that we have to be aware of that as leaders. It depends how we approach, our employees. It could be in hospital, it could be as a leader of state, it could be in the corporation. This will have an effect in their outcome of the pay of the employees or subordinates. And if we are angry, and cannot control our emotions, this amygdala will hijack the whole brain, and of course we will get angry. The others will get angry. Fear, depression, even. So we know now from the neuroscience that if we manage to manage our emotions and try to spread on better mood. I remember, you know, I worked before it was a university hospital in Zurich, and we had people who had the bleeding in the emergency room, you know, and really people, you know, we were fighting death and alive, you know, and we could see, you know, that the medical doctor that could, you know, was very calm, you know, he or she would spread those better moods. And somebody who was shouting, hey, Fadil, do that, Max, do that, do Paul that, why are you, you know, shouting around? So everything went chaotic, you know. So we have now, you know, data from the science, neuroscience, that will help us. And I want to wrap with this actually. So this emotional intelligence, it should be really, we should give more space in leadership and in managing crisis as well. So now I know that time goes very quick with marvelous people like you. We are very honored to get your questions, please. So I'm gonna stop this now so that we can maybe even see each other. And please do not hesitate to ask questions. I'm just going to read, so some of you, they asked actually some questions, so I have, but please feel free now in the meanwhile to ask questions. So I'm reading now those comments here. Dr. Abdullah, it's a great PhD student of mine and a great surgeon. He apologizes that I need to exit the lecture because he has to go back and fast, of course, to work. He's a surgeon. Really great lecture. So there are some comments here. Thank you very much, Professor Fadil. Thank you very much, our colleague Max Mano. Great, Paul. He was right, because I'm searching for questions. If it's any here. Yeah, I think go to question, yeah, as soon as possible. Yes. Do we have? Yeah, I will have to go in 2 minutes. For Professor Mano, unfortunately, he has to leave us. But thank you for joining us. Do we have any questions, those colleagues of ours who are still here? Please do not hesitate, and just turn on your microphone and just ask question. And that what we know, with pleasure, of course, we will answer it. And if we don't know, we will accept that we don't know, but we will search for an answer and find it if it exists. Please, colleague Pressure.
Hi, Paul. Thanks very much for the invitation. Hi, everyone. My question is around just the learning side of things, Paul, and also what I find really challenging to understand is from the scientific community why they are allowing themselves to be, shall we say, put beside political parties who are not telling the truth, which undermines their credibility. So there's a real danger that the 20, 30, 40, 50 years of credibility is just completely lost. And it's a lack of trust then, and leadership just completely capitulates. So how do we address this situation? Because I think it's... You know.
It's a great question, and particularly in light of the fact that we're already struggling with trust and empathy gaps before going into COVID. I am dumbfounded by how many very respectable scientists, including people I respect a lot, like Tony Fauci, have not stood up to their political masters. Yeah. And I understand that they were trying to, to accommodate, but the truth is that they are propagating some false beliefs and myths. And what they're doing is undermining the trust in future truisms, future science. And, the example that I alluded to around the chloroquine is a remarkable example in which a politician is dictating clinical care. Then lots and lots of people seek it out, only to discover the drug causes more harm than good. I don't know why. I'm disappointed at some leaders around the world who have, scientific leaders who have not spoken up more strongly, more boldly, more clearly about the role of science, about the role of facts. I think it's important that we speak about this issue, which is when you don't know, as a scientist, you can say, I don't know.
Yeah.
But that doesn't mean doing something that we know is dangerous because we don't know what's right. The trade-off is a false trade-off. And I just want to draw your attention to two relevant examples, Gareth. One is during and after the AIDS epidemic, two health ministers went to jail around the world. One was in France, one was in Japan. In both cases, they chose not to use a test that was developed, in this case in the US. They chose to wait till their own laboratories developed the test, ultimately exposing hundreds and hundreds of people to infected blood.
Yeah.
There is precedent for politicians making unethical decisions and ultimately harming a lot of people. And I hope that when the dust doesn't settle, but as it's settling, we somehow have the courage to start talking about the fact that many people died. Yes, died because politicians overrode scientists, and the scientists didn't speak up. And in some way, a collusion there. By not speaking up, they gave their own credibility to that. And that's a serious, serious issue. Because these are like massive experiments without ethics approval. If you think about the Helsinki arrangement or the Belmont arrangement, there are principles for conducting experiments. In some of these countries, the massive experiments, like in Sweden, where the mortality in Sweden right now is 10 times higher than in Denmark or Norway, 10 times.
Yeah.
11 times higher than in Israel, even though those countries have similar population sizes. Remarkable. So I think you raise a really good point, Gareth, about the accountability of scientists and where the public is just afraid to speak up. I think that's what that is. It's fear and just they've been cowed into silence, even though so much is at stake.
Absolutely. Thank you. Maybe I just will add something like that. I think we need, and especially to politicians, we need another approach now. I mean, we needed actually a long time ago, by the way. But, this ignorance, ignoring the others, ignoring the science, as Paul says, this is really, criminal.
Yeah.
I cannot say anything else, And what we are trying, actually with evidence-based now to tell people, so there are those 63 competencies that can be learned, if people want to learn. But the problem is politicians sometimes, in many cases, unfortunately, many of them, they are very resistant to learn and they never seek feedback, never ask for feedback, which they have the most needed, by the way.
Yeah. I just think, if you just take the UK and US, they're looked at, as being gold standard.
Yeah.
For example. So, I mean, when you have the lead politicians come out and say, well, we're doing really well. Well, you're not. You've got the highest rate of infection, you've got the highest rate of deaths, and then you're not being transparent with the statistics either. So when you're saying that we have X amount of deaths, it's not the reality because you're not including the deaths in care homes, for example. And
Absolutely.
so the whole system is not transparent. And then you have people who we know and we've worked with, and we've been in a system and we've had contaminated blood products in the past, which is an area I worked in, where we should be learning from these mistakes, where we know if we admit our faults, then we basically solve the problems. And whereas what we have at the moment is the same situation where we're making mistake after mistake after mistake. For example, if you look at Italy, we know from the data that it affects probably 1% of the population, but we're quarantining everyone, if you know what I mean. Whereas we could be putting support mechanisms around that 1%, but also we're sending that 1% to the hospitals and the public health system that will infect the whole system. Whereas we could be using private facilities and directing them to that private facility and keeping the current system open. So we just, there's no lessons being learned here. It's just all kind of all over the place. And we're spending millions of pounds, billions of pounds and it's no one has any control of it, and it's not going into new solutions or anything like that. It's not going. It's just kind of scattergun, you know. Like it's even EU are hosting hackathons, and they're inviting people into the health system who have no track record of healthcare, have no track record of quality or safety, and they're throwing in ideas which are going to cause deaths. You know, there doesn't seem to be any logic, and there's no clinical leadership either. There's no one saying from, you know, BMJ or Lancet, and everyone also is kind of leveraging as well for kind of more money rather than looking at, well, what are we actually trying to solve here?
Yes, absolutely. Thank you very much, Gareth. So I absolutely agree with you. Thanks. Do you have any other questions? Somebody else? Samira, do you have any question? I can see you there, but I don't know if some other colleagues are here. Yes, please just feel free, any of you. Thank you very much, Gareth. It was a very important question and statement of yours, absolutely. And in the meanwhile, just to summarize that, actually, what each of you said, this is ridiculous as well, that, you know, the world doesn't work together. Really, bringing the best experts, and as you can see, we have, I mean, I'm very glad, you know, in such a sessions, meeting wonderful people and specialists, you know, which can contribute to the field. Any other questions, please don't hesitate. I know we have been for 1.5 hours. Yeah, Samira, I think you have one question?
I don't have a question. I only want to say thank you for the presentation. It was really interesting. And I also appreciated the part of the women politicians that are effective during this crisis. And I hope that we're going to support women in leadership. So. Yeah. And yes, it was really interesting. Since I'm not from health, I'm a political scientist. It was interesting to hear something new, and yes, thank you very much.
Well, thank you very much, Samira. Samira Shabani, by the way, she comes from Germany, and she's, I mean, originally from Kosovo, but born in Germany. So I was born in Kosovo too. And she has done, she has completed her bachelor's in politics. And she has done a advanced studies certificate actually at the Academy of Leadership Sciences Switzerland, but really doing great. So I have a lot of that what we discuss now. I have hope, you know, that young leaders like her will make a better world, you know. And so our aim is to support, just as we are doing now with Paul, with Grant and all of us here actually. And good luck. She has written very good paper, by the way, Leadership and Gender, which we are looking forward to publish it soon.
I'd love to see.
Paul, it is work for you over there. It's work for you there as well. So you have to come on board.
Of course. Yeah. I must apologize because I had to step off. So I think we should wrap up, Fadil, or you guys want to continue?
We're going to make, we're going to wrap up because it is 1.5 hours. Thank you very much, Paul, for your time and great lecture here. And thank you very much for all of you participants here. Thank you very much, colleague of ours, Max. He went, I believe. But thank you, Brad. Thank you, Samira. Thank you all. Take care and all the best. Thank you.
Thanks, everyone. Thanks. Bye-bye.
Thank you very much. Bye-bye.